Good afternoon. It is indeed a pleasure for me to be here with you. I never would have guessed that. I guess it was maybe 15, 20 years ago, there was a professor at Jackson State named Diplomat. And she would periodically call on me and my wife of 60 years. She would call on us because she would have visitors from different countries, and she wanted someone to host events. And our friendship went way back, and she always knew that she could count on us. And our home became a regular stopping place for her visitors. And I never knew the implications other than people would come from different countries. We would meet, we would chat, and we would get to know different cultures. And I had no idea that 20 years later I'd be at this event, because I didn't know what the International Visitor Center was, other than we were an outlet for Diplomat to bring people from different countries. And here I am right now receiving an award. That was, I guess, over time you learn more and more. And that's one of my the advantages I have is that even at my age, I'm willing to still learn. And that's what has driven me to this project that I'm currently involved in, that I think has tremendous implications for your mission. As I have listened to different phrases, as I've attended some of your sessions and workshops, one common theme has been building bridges. And it occurred to me, most of what I've heard in terms of opportunities for building bridges has had to do with education, the arts, humanities. And in my mind, there was one thing that was missing, and that was health. And all I know is medicine. And at every workshop that I have attended, whether it was education, arts, or whatever, I could see how healthcare could fit into the equation. Because what I've learned during my pediatric residency, and you get this, I did a residency in Mississippi in 1965. Okay, your young people wouldn't have an idea or clue about what Mississippi and most of the South represented in 1965. Okay, Sarah mentioned that I was the only black pediatrician during her childhood. I was the first pediatrician who trained at the University Medical Center in Mississippi in 1965. Now, this is when we had laws. We had Tea Party type laws, okay? Everything was brutally segregated and enforced. Schools, public events, education institutions, healthcare providers, the few white doctors who would see black patients had segregated offices, waiting rooms, facilities. Everything was black or white and unequal. And to have the opportunity to do a residency was when I learned that healthcare, no matter one's political ideology. When I was chief resident, during the period that you're chief resident, you're responsible for the admission and treatment of all comers. At the time, 60–70% of comers of pediatric patients to the University of Mississippi were white. And during my tenure there was when they were burning and overturning buses, when they were using fire hoses and dogs on individuals who wanted to sit at a lunch counter, when they were denying education opportunities and other opportunities for blacks in my state and in other parts of the South. There was not one incident during my tenure as a resident in pediatric where a white mother looked up at me and said no. I realized then that when healthcare, the issue of race, segregation, ideology evaporates. A mother with a sick child wants the child treated, wants the child to get well. And there were those who cautioned me. It's part of my orientation for the residency. I was told, don't be surprised if there might be times when a mother refuses to allow you to touch her child because you're black. And I was happy to say that during my entire tenure there, not one incident in which a sick child was in my care, even though Big Brother Bubba might have been out turning over cars, just putting dogs on people, denying, waving the rebel flag. Big Brother Bubba might have been out there, but the mother put the trust and faith of this black dude of taking care of that child. And I realized then, and I realize that now, that there are opportunities within your mission to add a little health care. And I think you'd be surprised at how your mission might grow in terms of building bridges. Enough of that. I was told that you wanted to hear a little bit about me, right? Sarah has told you all about me. So let me talk to you a little bit about my career as in healthcare. It started with the idea that I would be a physician one day. I was the number 8 of a family of 8, the youngest of 8 children. And I was told and I was raised by a widow. My father passed and I never remembered. So the excuse of not having a father has never resonated with me, because I made it in spite of it. And I made it because it was declared, as long as I can remember, Aaron, you're going to go to, first of all, you're going to go to school. You're going to do good grades. You're going to go to college. You're going to graduate. And you're going to go to medical school. And you're going to come back to Mississippi and practice medicine. I didn't have a choice. It was laid out for me. The question of how you're going to do that, my mother was a domestic worker. How was I going to go to medical? You're going to medical school. And you're going to graduate. And you're going to come back home and you're going to practice medicine. What made it possible for me to go to medical school was that Mississippi, Alabama, Georgia, Florida, Louisiana, Tennessee, South Carolina had created something called the Southern Regional Education Plan. And those states appropriated money to the Southern Regional Education Board to administer scholarships for black boys and girls who wanted to go to medical school out of state. That was my ticket. My ticket was, in order to prevent me from even applying or wanting to apply to medical school at the precious Ole Miss, that we will make available to you full school tuition scholarship, fees, and a little stipend to go away. And the only thing yours is you come back home after you finish your initial training in medical school. So that's how I got into medical school. The state paid my way. The state paid my tuition with the requirement that I return to Mississippi and practice for a minimum of 5 years. I wanted to be a pediatrician, but the stipulation of the scholarship says before you can specialize, you got to come back and spend 5 years doing family medicine. We called it general medicine at that time. So, worked as a blessing in disguise because I returned in 1960, okay? I don't think I could have broken that pediatric barrier in Mississippi in 1960, but I was able to break that barrier in 1965. Now, I'm going to walk you through a few slides. I hope I won't take too much time. Someone told me I had about 15 minutes. I've screwed up about 10 already. And I came down to practice. I was upstairs resting, and the phone rang. They said, they need you downstairs at the reception desk. And I came down here, and they gave me this little gadget, and they told me to move your slides, you push this button. So I pushed that button. And that button kind of describes who I am when it comes to healthcare. And I'll tell you later what helped to shape this. But I found that as I started practicing, it was obvious that medicine, the shot that I gave you, the x-rays that I took, the tests and other things that I had an immediate but temporary effect. And that the long-term benefits of what I did wasn't automatic because, and I ran across this statement whose author was never identified to me. It occurred to me, and this was in 1970, when it occurred to me that in the social drama, sickness has a strong claim to being the arch-villain. It is bad enough that a man should be ignorant, for this cuts him off from the commerce of men's mind. It is perhaps worse that a man should be poor, for this condemns him to a life of stint and scheming, in which there is no time for dreaming and no respite from weariness. But what surely is worse is that a man should be unwell, for this prevents his doing anything much about either his poverty or his ignorance. These are photos from my early career at practicing medicine. These are individuals who, for the first time, had access to a non-segregated environment served by people who cared. Prior to this, they had to go to segregated offices, hospitals, and other healthcare facilities when they could. There were some counties in which there were no physicians at all. And these are shots from my earlier attempts to make a difference in the provision of health care. That's a typical environment. If you come to Mississippi, when? What? Later? Next month? Early next month?
28th of February.
February. Oh, that's tomorrow almost. You'll see some of this. You'll see some of that. It's still there. That was 1970. But you'll see some of that. And what we discovered, the system that we had put together created a first-line intervention. But we discovered something after a while. We would treat, give them the best of care, and this was the typical scenario. We would treat, we would hospitalize and send home. The person would go back to that environment that you just saw, and it created this type of revolving door for the hospitals, even for the clinics. If they weren't sick enough to go to the hospital, same scenario. This was the scenario. Still exists in some places. Still exists. These are the kind of circumstances that exist. Even after millions and millions and millions of dollars in the past decade being poured into the Mississippi Delta under the pretext of making a difference, of eliminating that type of scenario where you treat, you do the best you can, you send patients home, and over and over and over, you see the same disease, the same condition, the same problems reoccurring because of that environment. I can show you a little piece of paper to show you where $102 million went to one agency, Tea Party type, in the Mississippi Delta in the past 10 years. And it had, at the time, under the pretext of reducing the health disparities that existed between the black population and the white population. $102 million last 10 years. And instead of the disparity 10 years ago was like this, the disparity 10 years later, after $102 million, actually got like that. After all those investments, the region stays still faced with the kind of challenges you see here. Health, education, economics, poor health status, limited education. And that common focus, the second bullet, combined with short-sighted vision, history, and culture of the region, which is characterized by persistent racism that leads to discrimination against individuals in areas like the Mississippi Delta, where we have high proportions of African Americans. And these are just some of the documented bad statistics that prevails amongst the population that we're concerned with. Obesity, childhood poverty, low graduation rates, insufficient number of physicians, hospitalizations that could be prevented, infant mortality, and deaths from chronic illnesses. This is just a snapshot of the Mississippi health rankings, and that circle represents the area of special concern, which is the Mississippi Delta. It's called a delta because it's located along the borders of the Mississippi River, and prior to a levee being built, that area flooded each year, each spring, and with the flood there was a deposit of silt from the river, and it built up 2-3 feet of very, very rich soil. They created opportunities for growing veggies and other products, and that's what drove the economy in the Mississippi Delta. That's what drove the need for plantations and sharecropping. And if you get an opportunity, or if my wife corners you off, I can assure you she can talk to you a lot about that, because that is where she grew up. And she's working on some special project. She has a passion like I do have a passion. So, after all of that, realizing all of that, it became very frustrating. In the position I was in, I had access to resources and money flowing into the area under the pretext of being used to close the gap in healthcare. But those resources were being used for other means, and they were not having the benefits that you would expect when you spend that kind of money. So we decided it was time to try something new. And within the Jackson State University, there's a College of Public Service, School of Public Health. In that school, there's a professor who's a dual citizen. He's an Iranian citizen, American citizen, who works in the School of Public Health. Our path crossed so many times. And during over the period of time that we had met, we had talked about, and he'd heard me. I didn't quite shed tears, not visible, but he had heard me talk about the frustration that I personally had in seeing so many resources being poured into the Delta area, but very poor outcome. And he reminded me that in his country, they had similar problems. Rather than being racial, the disparities were geographic. And he described to me a model there in which over those 10 years where we spent $102 million, and it went like this, they spent a fraction of that, and it went like that. So it got my attention to the fact that I said, I want to see it. And he I told you, get your passport, you're going around with me, and you're going to take a look at it and see what you think, and let's come back to Jackson and see within the confines of Jackson State University and the medical mall, we could put together a model and replicate what we saw in Mississippi. And this is just a description of how we went through that process. I'm going to just kind of go through this kind of rapidly. So we met with local communities, Baptist Town, Balanced View, several other familiar names in the Mississippi Delta that we recognize. And we decided that we would try and replicate the model that we had learned about, that we had the opportunity to observe firsthand, and to meet the people and to see the community health worker, the system that they had set up there that was so what we would call cheap, but very, very, very effective on the basis of quality, outcome, and access. So we decided that we try to replicate that. And a brief description of that model is graphically. This was our trip in 2009 where we went over. This was in Shiraz. This was, I have high blood pressure under control. And that was one of the community health workers in a village, a remote village. I don't have a clue. It was someplace way, way, way outside of Tehran. That a community health worker checked my blood pressure, assured me that I was doing okay, looked at my medicine, said, yeah, you got the right stuff, and you're doing fine, get plenty of exercise, drink a lot of water. And I said, okay, that's the same thing they told me at home. So it made the news. It made the news. Aaron is over there where he shouldn't be, learning stuff that he's going to try to bring back and impose on us here in Mississippi. And there I was over there making friends, building bridges. That's a student, medical student in Iran. He has a passion to one day when he gets his medical degree, and we're paving the way for him to come to Jackson and get his Master's of Public Health as a result of the relationship that we have built. He's going to get his MPH. He's going back to Iran. He's going to improve the overall ability to do his job in Iran because he will have more skills, more resources related to combining his primary care practice and infusing public health principles in his public health, in his practice. That's Baptist Town. No, that's not Baptist Town, that's Belzoni. That's another area in the Mississippi Delta. And that's me and one of my colleagues, after we'd been to Iran, we were looking for places to drop a health house, to create a health house. And I'll show you what the health house, when we talk about health house, what that means. Let me back up. After we became convinced that this model in Iran could work, Dr. Shabazi identified the architects of that model, put us in touch with them. We had several meetings with them. They agreed to come to Jackson and meet with key policymakers related to healthcare and education in Mississippi to explore the possibility of their helping us to put together curriculum and everything for the training of community health workers. And we would eventually set up a center there at Jackson to train community health workers that would do the kind of services that you saw the young lady in Iran with me in the health house there. This is an event when they were here, when they were in Jackson, we had a several-day conference, and this was one of the conferences in which the Iranians were helping us think through and plan through how we would implement their great model in the state of Mississippi. This is a group shot, educational officials, health officials, and this, in a nutshell, is what it looked like and how it worked. In our country, our health systems in most cases are fragmented. We have the hospital that does, most hospitals Great job. Best of service. Best of treatment. They treat the patient and they discharge the patient home. The primary care physicians and specialists outside of the hospital do a great job. But the patient becomes a patient of either the hospital or the primary care outpatient facility. In many instances, when that patient goes from the hospital back to the primary care doc, or from the primary care doc or the specialist into the hospital, the information and procedures that have been provided at one level is not transmitted to the other level. So there's often a repetition of procedures, services that cost money. You hear our president, by the way, in Mississippi, about 57% of the population still does not recognize that Barack Obama is the president of these United States. It's still in denial. Can't be. Somebody told us we bought that at the White House. That can't be. That's a whole nother story. Well, anyway, in Iran, that bottom level of care is the health house. And instead of an individual patient, a typical village of 2,500 individuals in a remote village in Iran, within that village, there are at least 2 individuals, a male and female, that's trained and certified as a community health worker that is linked with the primary care, especially outpatient specialist, that's also linked with the hospital. So a patient that's in that network, it doesn't matter where the entry point, whether it's in the emergency room of the hospital, whether it's in the primary care physician's office, that patient becomes a patient of the entire network. It becomes a patient of the, if it's originated in the hospital when they are discharged, that patient is also a patient of the primary care or specialty clinic, and they are also a patient of the community health worker. So when the patient is discharged from the hospital after an acute asthmatic attack or a diabetes crisis, and they're discharged home with certain instructions, take so much insulin, X number of times a day, take this tablet at morning, this tablet at noon, and this tablet at bedtime, drink 8 glasses of water, get at least 30 minutes of exercise a day. That community health worker is aware of those instructions. And that community health worker lives right down the door, right down the street, across the village. And they know that when this patient was discharged from the hospital, these were the instructions. So within 48, 72 hours after that patient returns home, the community health worker is knocking on the door. Did you get your insulin as you were instructed? Is it in the refrigerator? Is the electricity on? Are you taking the morning tablet in the morning? You're not sharing your insulin with your husband, are you? And you would be surprised that those simple interventions prevents so many of that revolving system that I just described. Community health worker with a equivalent, a high school or equivalent education with a special training and certification is now a member of the team and a member of the network that is now providing care to the village or to the Baptist town or to Balanceview or to a typical Mississippi Delta community. And these are the kind of results that we have had an opportunity to try. Remember the slide? Remember that? And that? We found somebody who was curious. United Healthcare. They heard about my travels, and they say, we'd like to help you take a look at it and see how it can work. And there was a local hospital in Jackson that was having difficulty with that revolving door. So we were able to implement and add the health house, and the primary care, and the hospital to create the kind of network that I've just described. Look at the difference in the result. Look at the number of people who are going back to the hospital unnecessarily because they couldn't comply or wouldn't comply or didn't know how to comply. You know, when a person is in the hospital and they want to go home, you have your nurses and all the social workers and all the people coming by, and they got all these papers and say you got to sign all this before you go home. And do you understand? If you want to go home, you're going to say, yeah, I understand. I understand. I want to go home. I understand. And you go home and you put that paper in a drawer and you fail to comply, and then before you know it, you're back in the hospital. But now we got somebody come knock on your door and say, are you doing what they told you? And these are the kind of results we're getting. We're proving. So much so, we've created within the medical mall this training for the community health workers. Sarah mentioned an opportunity of going to Iran to get further training to the point where she is now an official instructor within the School of Health Sciences, School of Public Health, Global Center for Training and Certification of Community Health Workers. The young lady on the slide with the red scarf, she's also an instructor. She was a former welfare recipient. 2 kids on welfare, motivated. We were able to convince her that there's a better life for you. She completed the training. She had the same opportunity to get a passport.
Never been out of Mississippi.
And never been out of Mississippi. And now she is an instructor of potential community health workers for the future. They're going to be training residents of the Mississippi Delta that represents a typical remote village in Iran. And they will be doing the same kind of intervention, part of the same kind of network in that country, in the Mississippi Delta. And these are the people who will be doing the training of those community health workers from the Mississippi Delta. This is Sarah and the others getting their certification. Keisha Island in Iran. And there they are before departing. And they will be training individuals like this in the future. And guess what? We got some challenges. You remember I mentioned something called Tea Party? Guess what? Look at that. They heard about it. They heard about what we were doing. They heard about what we were doing. They heard that it was connected to the country of Iran. How dare you? So some smart introduced some legislation last month that says an act to prohibit community health workers from performing any function that is within the scope of practice of any profession or occupation licensed by the state of Mississippi. Unless da 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 da. And what that means is the people that we're training even if it's your sister, if we call her a community health worker, she can't come and help you understand what they told you when you left the hospital, because you will be breaking the law. That's typical. That was caught us by a little surprise, but we'll overcome that like we overcame the back of the bus and separate waiting rooms and separate facilities. We'll overcome that. We won't be deterred. But this is the reaction. Instead of somebody in my state legislature saying to the Department of Medicaid, where they're crying about how much it's costing, and those days in the hospitals are increasing, and the use of the emergency room, and da-da-da-da-da, and the complications of all these diseases costing us a whole lot of money. And then here's a cheap intervention that could vastly improve on the amount of money being spent on hospitalization, non-compliance, complications, and some person introduces into the state legislature something to prohibit it. That's one challenge. The other challenge is this. I mentioned the United Healthcare Foundation made it possible, in part, for the establishment of the training center, and those resources have been expended. Now we're revving up for another group of trainees, and the United Healthcare support was used to help pay the tuition to the Jackson State University for the training of those community health workers. That's gone. So now the other challenge is replacing those resources so we can continue to recruit, train, certify, put on the ground, create networks that will prevent a lot of complications, save a lot of money, and make life better for so many of my Mississippi citizens. Thank you.